Sidewalk Labs is this amazing opportunity to bring a bunch of technologists together with a bunch of urbanists to take advantage of the amazing things that technology has to offer with a deep understanding about what really makes cities tick.
Instead of saying a problem is just about technology or it's just about policy, in most cases the answer is it's both. We find the very best people in the world who can go and think about solving those types of problems.
So with that, I'm pleased to welcome our first speaker, Lauren A. Taylor. She is a health services researcher based at Harvard Business School. I have heard of it, where she is pursuing her doctorate in health policy and management. Lauren will talk more about those social and environmental determinants I mentioned a few minutes ago, those non-medical factors that make up a person's health outcomes, because she wrote a book on it in 2013, The American Healthcare Paradox, Why Spending More is Getting Us Less, co-authored with Yale's Elizabeth Bradley. Please help me welcome Lauren A. Taylor.
Okay, it's great to be with you guys, and it's especially fun for me because I've now been talking about the integration of health and social services for 3 years since the book came out, but usually I'm with health policy folks or I'm with physicians, healthcare administrators, and so this is a really new audience for me, so I hope I get some new questions, and I'm really happy to be here. The experts are really behind me, so the new questions I get, I don't know the answers to them, they pick okay. So this says a 10-minute plan. I was granted 13 minutes, so this is what I think I'm going to try and do with it. One is to try and give you a rationale based on some of the data that I've been a part of generating about why would we even be talking about social services or social determinants of health when we're trying to think about improving the quality of care and bending the cost curve. Second, I'm going to try and outline very briefly some models of integration and care coordination that include both health service provision and social service provision. And then third, I'm going to try and just identify some of the key challenges, both at kind of the strategy level if you're a healthcare provider, and more broadly conceptually, like for the field, what are the big unanswered questions? So first things first, this is the book on the left, and I like to start there because that's really what brought me into this space in the first place. And the question that the book was trying to answer was, how can we have such a large discrepancy between what we spend on healthcare in the United States and what we seem to get from it? So top right, you'll see a graph that you've seen a million times, I imagine. It's percent of GDP spent on healthcare for all of the OECD countries. And I've made it very small so you don't have to worry about the details. All you need to know is that the US swamps virtually every other country in the OECD. We're up around 18%. It's enormous. That would be, I guess, justifiable if we thought that we got great health outcomes for it. And yet, if you look at some of the big markers of kind of population health, we really don't seem to do so well. So if you look at something like maternal mortality, there are 32 countries in the OECD, we rank 25th. If you look at something like life expectancy, we're 26th. Low birth weight infants, we're 28th. And so just for reference, because sometimes I'll give those stats and people say, well, the OECD is all kind of industrialized Western countries, so how bad is that really? On the bottom, I've put our global rank. So if you look at the United States, it spends 18% of its GDP. Global rank for maternal mortality, we are 136th, which sandwiches us directly between Ireland and Hungary. And so this was kind of the motivation for the book. For a long time, health policy people have been really puzzled about how it could be that we spend so much and don't get great health outcomes. And myself and Betsy, my co-author, were trying to offer a new solution for why that might be. The answer we provided is one that was not really novel if you came from a public health background. There's been decades of literature on this, but it was kind of novel as far as a policy discussion. And the answer, we said, to why these two facts could coexist is because most of your health really isn't determined by your health care or your medical care. So if you look at all the data, somewhere between 10 and 15% of your health care is really directly attributable to both the access you get to health care, how quickly, what are the quality of the doctors, and things that are kind of all in that bucket. Okay, so about another 10-20%, depending on the study you look at, really says it's about your genetics. You know, if you have the BRCA gene, you're in trouble. And for a long time, people would talk about the genetics box as a black box. There's nothing we can do about it. Now we're starting to really think about epigenetics and the mutability of our genetic code. But somewhere between 10 and 20% is chalked up to genetics. But then that leaves this like big bucket of things that really are what the best research tells us the determinants of your health. And those are social, environmental, and behavioral factors, which from here on out, I and others will shorthand as social determinants of health. What do we mean by this? We mean, do you smoke? How much exercise do you get? How much sleep do you get? What's your stress level like? How high quality is the food that you take in? What's the quality of your housing? What's the quality of the air and the water you drink? And I'll just say that when I started this in 2013, I used to give the example of water and people would laugh at me and they'd say, Lauren, you're importing examples from your global work. And now we realize it's been front page news, there are people in this country who do not have clean water. So these are real things that really impact people's health, but those are kind of the concrete examples that we're trying to bring to life under the umbrella of social determinants. So the challenge we had was how to build in this kind of passed down wisdom about social determinants into an empirical study that could say to policymakers, look, spending on social services and social determinants is really important. And so what we did to try and operationalize that big orange chunk was to say maybe we could build into traditional analyses the spending that a country does on these sorts of things. So employment programs, supportive housing, nutritional support. When we did that, this is what the graph looked like. So you'll remember the little bar chart that was in the previous graph where the US was a huge spender. Here you'll see the same OECD countries on the x-axis, percent of GDP on the y-axis. Our blue bars are still percent of GDP spent on healthcare, and the orange bars layered on top are the percent of GDP spent on social services. So the US has moved into a more middling position. That being said, the most perceptive among us may notice that the US is really actually quite distinctive and in one other way. And that is that our blue bar is bigger than our orange bar. Virtually every other country in the OECD has a larger orange bar, meaning they give more money to their social service spending than they do their healthcare spending. So we did one more manipulation of the data, which was to create a ratio of the social service spending to health service spending. And when you do that, you find that the US has the smallest ratio of social service spending to health service spending of any country in the OECD. If you wanted to summarize this graph kind of in words, you would get something like this. In the US, for every $1 spent on healthcare, an additional 90 cents roughly is spent on social services. Whereas if you took a hypothetical OECD country, each $1 of health service spending is matched by $2 of social service spending. So it's really an inverted mechanism or an inverted allocation that we have going here in the US. The key question, of course, is whether or not that ratio is predictive of anything. You can't get papers published, and no one will pay attention to you if you can just describe the data in fun ways. So thankfully, this is the paper that came out back in 2010 or 2011 now, where we actually plugged this all into regression and said, okay, is this ratio more predictive of health outcomes than the health service spending? And in fact, it was. So that ratio better predicts things like less infant mortality, premature death, longer life expectancy than the health service spending alone, which was kind of our big aha moment of maybe we should really broaden the focus of health policy discussions so that we're not always trying to figure out how to fix people and spend money differently on insurance and MRI machines and care coordination, but really think about other domains of spending that could move the markers on health and predictably probably bend that cost curve better than anything you could manipulate inside the medical care system. I should note that this original paper has since been replicated by RAND. We did a follow-up study that was looking just at the state level, so among the 50 states, we created that same ratio of social health spending and found that again, it was more predictive of all sorts of health outcomes than its medical spending alone. And we've got a follow-up paper in the works that kind of extends it through more years of data, but once again, we're finding the same result. So it's a pretty durable finding, if you ask me, of course, but I'm happy to give you any of the sites that you want, or you can go find them on your own. Rand's work especially is like flabbergastingly good. So go ahead and let it bear scrutiny. So today I talked about kind of social services or spending on social services as a block, and this is just a slide to try and give more granularity to it. So this is a lit review that I co-authored with a team that tried to ask the question, so which social services really produce better health and potentially save healthcare dollars? And the answer was there were 3 buckets that really stood out from the crowd. The first is housing, the second is nutritional support, and the third is case management. There are caveats and kind of nuances to all of them that I'd be happy to talk about during Q&A. But the real note on case management, which I think is potentially the most controversial because there's just so much spending on case management now, and we're getting mixed results. Some case management programs see you to save a lot of money, and others seem to not save so much money. My own perspective on this, and Mimi will be able to speak better to it, is that whether or not you go into the home matters a lot. So case management with home visitation to me seems to be very effective. Case management over the phone, or that has less of kind of a personal touch, seems not to be so effective. So given all of this evidence, and kind of given the recent upsurge in discussion of social determinants of health, you're seeing policies at both the federal and state and kind of the funder level, which is very important in health services and social services, bend towards trying to both incentivize and support the integration and coordination of health and social services. This is in part because no one thinks that it's a politically savvy strategy to go and say, we need to take from health services and give to social services, which would be a very literal implication of the ratio findings. So instead, people are trying to kind of say, well, maybe we can integrate them or coordinate them more thoughtfully, and in a sense, like borrow dollars from healthcare to spend on social without actually taking from the budget line. So here you've got a lot of policy soup, but you've got things like the Accountable Communities of Health, which is a federal program trying to get communities to apply to the federal government for chunks of funding as a community, and then allocate dollars between health and social services as they wish. Accountable care organizations are doing some similar things. This is a state policy district that, again, Memi would be able to speak better to. And then RWJF, if you don't know that acronym and you're coming into this space, get to know it because they seem to be leading the way as far as funders. It's the Robert Wood Johnson Foundation, and they have really, I think, commendably shifted the Titanic in terms of really incentivizing and promoting social determinants of health. So this is the model spec, and I have to say, I always start with healthcare because I'm a health services researcher, and so I'm biased in that direction. But the way that this slide is set up is thinking, okay, how does healthcare start to move beyond the four walls of itself and try and collaborate with social service providers? And so if you work left to right, you can think about ever more progressive ways of integrating health and social services. So you've got a traditional healthcare sector, four walls of a clinic or a hospital. In some cases, you see kind of a light touch gesture towards integration. We have some employment of case managers, patient navigators, care coordinators, an acknowledgement that like just navigating the medical system we have constructed is incredibly overwhelming, and so we try and give people support to do that. In some cases, those people will also help patients to enroll in other social service programs, but that's usually the extent of it. Kind of next layer over, you'll see many hospitals, clinics start to actually offer individual social services on site. So for instance, in Boston Medical Center, one of the big former city hospitals in Boston, they actually have a food pantry on site because they got tired of referring clients to go to a food pantry or try and solicit or kind of acquire higher quality food. And so they decided, screw it, we're gonna build it on site, and that way we kind of lose the coordination costs associated with working with the food bank. Programmatic partnerships have become all the rage, the most popular I think being medical legal partnerships, where a hospital or a doctor's office or a clinic will partner with a legal aid society, and the legal aid society will be on call to help especially Medicaid patients remedy kind of legal troubles that are really standing in the way between them and health. So the prime example is you've got a low-income family, they've got a child with asthma. The asthma is continually exacerbated by something in the home, right? Mold, pests, something like that, and they're in a rented apartment that a landlord controls. The family's been talking to the landlord for a long time, trying to get the air cleaned. The doctor realizes that this child is churning in and out of the ER, emergency room, costing a lot of money, but the doctor has no particular skills in advocating with the landlord, and so that's where a partnership with a legal aid society can be incredibly valuable. In some cases, you have like full co-location of services. In the book, we talked about the Herrera Center, which is actually an example from the Veterans Administration. And I would just say I don't think it's surprising that you see the deepest level of integration in the Veterans Administration because in a sense they are a single payer, and they're a single payer both on the healthcare side and on the kind of social services side, which they call benefits. And so if you are a single payer, you can recoup all of the savings from making upstream investments in a way that, given the fractured nature of the standard healthcare system vis-a-vis the social service system, it's very hard in many cases to try and capture the savings. So for instance, if a state makes a large investment in housing, that decreases the amount of kind of ED services that someone uses It can often be the Medicaid managed care company who is insuring those people who recoups the cost instead of the state. And so it's just a classic externality problem, or what they call a wrong pocket problem, where often the person making the investment is not the one getting it back on the backside if the investment actually bears fruit. And then lastly, I would just note, I think in some ways the holy grail here is kind of pooled health and social service budgets at the local level. So this would be standard in much of Scandinavia, who I think does the best job of this, and often gets the best health outcomes. They will actually deliver a pot of money from the federal government to like their version of the state and say, look, think integratively about where you want to put this money. Do you want to put it into fall prevention and kind of home remodification? Or do you want to wait until people fall and kind of continue to put it in MRIs and fixing broken bones and broken hips? I would say if you're a healthcare, this is now the challenges bit. If you're a healthcare provider, these are kind of the big challenges that stand in your way from trying to get people to actually integrate. So you have questions about how and who to screen for social needs. You've got questions about how to provide social services. If I decide I want a food bank, do I build that in-house or do I contract it from an existing provider? How do I vet potential provider organizations? It's very difficult to know who's a reputable provider and who's not. How to share information. A lot of patient protection says like you can't share information with non-medical providers. And then also how to balance social determinants and medical care. In some cases, if you do too well keeping people out of the hospital, that bites into your revenue stream. And if you're running on very small margins, could put you out of business. And lastly, I would just say the big conceptual question here is kind of what role should healthcare be in creating health? So if we're trying to create a healthy population, we could think about two different hub and spoke models. One is healthcare's at the center. They're quarterbacking everything, in part because they've got the most managerial expertise and the most money. Everyone else plugs into them, but they really own the reins and manage the care and own the risk. Another would be you pop healthcare out to a spoke position, which many healthcare providers would prefer. They say, don't put me in the middle, Lauren, you just told me I'm only worth 10% of health. There's no reason for me to sit in that central position. But if you pop healthcare out, the question is, who really would govern this? If I'm talking to a group of Europeans, they're always like, isn't that the role of local government? Isn't that why we have government? In the US, that's not usually the result, but if you don't think that, then there's this big governance question and a vacuum potentially about who should run this. Thanks so much.